Hi, this is John Kanellopoulos from our office here in Athens, Greece, the LaserVision Ambulatory Surgery Center, clinical professor of ophthalmology at NYU Medical School in New York City, New York. Here's yesterday's case. This is the left eye of a lady I had done LASIK on about 20 years ago. We can see here on the Optos wide field that the left eye, which is on the right hand on our screen, has a dense cataract, and here we can see what's left behind from that successful LASIK for about a -10. We can see the pentacam, slight decentration here on the pentacam. When we view a procedure performed 20 years ago, today we use the 5mm total cornea measurements as the means to calculate the keratometry with the current interferometry. These are the placido disc topographies, also showing some nasal decentration. And also, of course, the interferometry by the Tomei device and lens star. We, of course, will look at endothelial cell counts, which are suggesting Fuchs endothelial dystrophy, although the cornea thickness is relatively good. Our lens star measurements as well. And we're focusing on the left eye that has an axial length measurement of over 27 millimeters. And left hand side here, we're looking at all the different keratometries. As I mentioned, we use the 5mm total cornea case for the pentacam. Comes up with a toric lens. Our go-to is to do a calculation as is with the lens star and add 2 diopters, similar numbers with the ACRS post-LASIK protocol here with an average of 20 some diopters. We want this eye to be myopic, so we aimed for a 21 lens with a toric Akersoft calculator. So this is 92 degrees at T3 at 92 degrees. We're starting the procedure. We had recommended this lady had cataract surgery 5 years ago in 2016. Nevertheless, she waited for quite a while, and she is in her early 60s. She's only 62 years old. So she was almost 40 when she underwent LASIK. First problem here, small pupil. This is after vigorous topical mydriatics, rinsing off the surface. I always do surgery with a short-term peribulbar anesthesia, lasts for about an hour. I use 5 cc's of 2% xylocaine and 5 cc's of normal saline, and of course white ACE. This lasts for about an hour. So during the procedure, the patient is doing well. Beveled incision here, always at the 135-degree mark, and paracentesis. This is a right eye. I'm over the nose here with the same 275 alkaline keratin, but only partially. To enter in an under 1mm paracentesis, we'll use epinephrine here, diluted epinephrine. We can see we'll get a nice kick in the pupil dilation, and we still can't appreciate how hard this lens is. Classically viscoat, especially in this hard lens. And I'm jumping into the part that I realize that I have a rent at the top left in the image here, which is basically the 5 o'clock position. And this is what this case will illustrate. What should we do at this point? Convert all of this into an extra cap. I will use viscoat to fill in that gap. The lens has not sank down a lot, so I am going to try, after making sure that the retina guys stand by, to see how much of the lens I'll be able to emulsify. We're seeing that despite Fuchs, the cornea is relatively clear. I've used copious viscoat during the initial divide and conquer. The lens is already divided into 4 segments, and I have a very stable anterior chamber, especially now that I filled the infero. This is a left eye, so the inferotemporal rent with with viscoelastic. A few moments here of reflection and consideration, and this part is unedited, and I'd like to show it to you as such. I'm going to use a Kugelin and a Sinski to make sure I separate these lens fragments very nicely. We can all appreciate how dense this lens is, and in retrospect, maybe an extra cap here would have been a best solution. But we can also see how large the lens has become and how rigid these particles are, and we're constantly under the risk of and the possibility that this lens may at any point pop into the posterior chamber and may require more laborious procedure. But nevertheless, I'm going to go forward since this quad is asking for me to phaco it, and I'm going to, and I apologize for this image being a little bit off camera, to carefully emulsify this quad of the lens. It's the smallest one. We can see that it's almost attached to the lens, to the rest of the cataract. But I'm pretty successful in chewing up with my phaco device, and I use the White Star signature device here. I'm with phaco power at 40%, and here I invited in some posterior capsule again. So we're going to reiterate the maneuver of injecting some viscode into that rent opening. I'm contemplating here how much of the lens is left behind and whether I'll be able to open the incision and fish it out with a loop. Still, this would be a very large incision. Remember, I'm at 2.7 in my major incision, and I got away with one quad, so I will attempt to, after we get a second tube of viscode ready, and we see it in action here, to lift the lens up a little bit from the capsule, push a little bit of viscoelastic into that inferior rent to brave this out, and to try and emulsify as much as possible as I can, to at least bring it down to the point that I can pull the piece out. You're going to see me going back and forth quite a while. I know that this video may be quite painful for some of you to watch, as I'm now rotating the residual lens in a way that, number one, I can pick it up with a lens loop. Number two, I can endeavor into chewing up some of the loose ends, again with frequently breaking and filling the chamber with viscode to protect the very sensitive endothelium, as we saw that this lady has the beginning of Fuchs endothelial dystrophy. I'm able to pull in this quad of the divide and conquered, well, divide not yet conquered cataract, so to speak. Let's not get ahead of ourselves. And very carefully, I've lowered the bottle, so I have low pressure in the anterior chamber. I'm very careful to make sure that no piece is left loose and allowed to drop into the posterior chamber. We can all see this round rent that extends in our surgeon's image supero towards the left, and in essence this is a infratemporal rent of about maybe 70-90 degrees in arc, and at this point I will proceed in debulking as much as possible this ferocious nucleus. Only if I had predicted that this lens, and you saw in the beginning that the red reflex was very deceiving, we felt that this lens would be maybe a 3 or 3.5 out of 4 being worse, or 4 to 5 out of 6 being worse. But this is a 4 plus, with 4 being worse, and possibly 5 to 6 with 6 being worse, depending on which classification you use. So I'm going to push back the posterior capsule. We're very lucky we don't have any vitreous in the wound. We can see the very nice continuous capsule rhexis that's holding place, and I'm already in my mind planning on using it to put in a sulcus lens. I've already asked my nurse to calculate that. And not only here, we have a post-LASIK calculation with a goal of -1.5, since this is going to be the myopic eye of the two. I'm having enough room to come in with a lens loop. I have almost half of the cataract there, the nucleus. My opening is not big enough. Probably around 5.5 millimeters, maybe 6, but this being half the lens and plus more will require a little bit bigger. Very careful here to use my keratome in an angle such as to maintain that initial, or maintain as much as possible that initial beveled incision, phaco incision that would require less suturing and obviously less astigmatism post-op. I'm engaging here the nucleus left behind, and we will deliver this very, very hard lens. I do not want to manipulate the anterior chamber much, so I'm going to fish this rock hard nucleus from the outside, keep it as a souvenir, and then use viscoelastic to express. As you can see here, I don't have vitreous in my wound yet, but I'm already setting up an anterior vitrector, and the one on the signature white star is an excellent one. And here I'm using viscoelastic to express all the residual cortical, rather nuclear material that's left behind. We will go back and remember our art of extracap, although this is kind of a converted extracap with a incision of about 6 millimeters, I'd say. So I can probably get away with 2 or 3 sutures. Our 10R nylon is armed and ready to go. We'll go in, and this is very important, especially for beginning surgeons, to be very careful here and very thorough, and try and suture this in a way that we will not create a step in the cornea and the limbus, grasp part of the clear cornea that's under this beveled cornea incision, go through the sclera, and this way have a very good seal in the beveled cornea incision. I have to go through conj at some point. This is at this point a little elusive. I opted not to create a pre-operatively at this point. I was able to go through with my 10-0 nylon needle and throw in a square, 3 square knots here, and then explore the anterior vitrectomy pathway, which again we have to be very thorough. We want to debulk the anterior vitreous, create a scenario where this case that is quite challenging will end up as a normal phaco case, and time here is not of essence. Although my average case, and I'm a relatively slow phaco surgeon, since I like to do every step of the procedure, is anywhere between 10 and 12 minutes. We will spend a good half hour in trying to make this look not only good, but explore the best possible visual outcome. As I mentioned prior to this, the astigmatism for the T3 was with the rule, and this is why I opted to run with the enlargement of my incision towards the steep axis of the planned toric lens, and use my incision as the means that will reduce the cornea astigmatism post-op. As we know that when I remove my sutures, the wound will relax a little bit and reduce that with the rule of astigmatism. I am using my IA here, and I'm very ambitious that this will not pull in vitreous. And of course, I've lowered the bottle of the White Star signature device. I'm very good in getting away and removing cortex, and remember, leaving cortex behind here may be the worst thing of anything, even worse than the capsule rent. I will fill in again the opening with viscoelastic. There's always a golden medium on how much manipulation I will do with irrigation aspiration, and when will I jump in with my vitrector. I'm trying to get away in removing as much as cortex as possible, since viscoat is acting as a nice seal and not allowing my water to go through the rent. And at some point I will give up. I'll jump in with the vitrectomy device, very high cut rate, 800 to 1000. And this is one of the nice perks with the signature White Star device. It has been our go-to device for at least 5 years now. And you can kind of see me somewhere down there on the picture-in-picture. I use a dark room, so everything seems quite dark in the OR room. We're setting up the vitrectomy mode and this device, and we will go in with irrigation and vitrectomy to debulk the anterior vitreous. And here we go. And as I mentioned before, I'm running this real time in order for us to also appreciate the real intraoperative environment and how these things run. I want to make sure that my vitrectomy probe is functioning well, so I will test drive it a few times. I do not want to go in with just aspiration. I want to make sure that the cutting rate is at par and at the level that I like. And as soon as I'm convinced that my vitrector is up and running, I will engage it through my paracentesis and just go through the rent into the anterior vitreous cavity and just start debulking the now hydrated vitreous material, and reduce the possibility of a prolapse. I'm spending a little bit of time here, and I'm quite thorough in removing as much as vitreous material. Also, you can kind of see all the myopic imperfections that are present, probably viscoelastic as well, in the posterior cavity, being very nicely vitrectomized with my probe. I'm using my second hand, my right hand, through the initial incision for irrigation. The bottle is very low, and now I'm cutting my cutting rate to 0. I'm going to use my vitrectomy probe as an irrigator aspirator to complete the removal of the cortex. As I mentioned, this is a very critical part of a successful procedure that we have converted into a mini extracap anterior vitrectomy. So we'll use viscoelastic again to fill in the capsule bag. We will go in with irrigation aspiration. We don't have any vitreous prolapse here, so there will be no pressure of material coming in from the rent. And see how things become far easier now. It's as if I'm performing an IA in an eye with a complete capsule bag. So I am engaging the cortex. I'm very pleased that I'm seeing less and less cortex and more a clear capsule bag. And through this whole small adventure, I'm preserving a very nice anterior capsular ring as a scaffold to place the sulcus 3-piece lens, which we have already calculated to include the fact that it's going to be placed more anterior, and we're going to take out 1 diopter of what we would have calculated that lens to be if it was placed in a capsule bag. Now, with the lenses that we use, this is going to be an MA Acrosoft lens, and it does not have the option of astigmatism, and this is the reason, as I mentioned before, that I enlarged my incision towards the steep axis that this patient had prior. Here's our lens. It's a MA 60 lens, power 21. It's a 3-piece hydrophobic acrylic lens. I do not have to enlarge the incision further because I will fold the lens and it will comfortably go through the quite large incision that I have, even with the one suture. I think one side has at least 4 millimeters. Nevertheless, for better control of implantation, we will fold the lens, orient the haptics in the direction of favor. Again, very careful here in coming in just flush with the pupillary aperture. We're not seeing it well here, and definitely over the anterior capsular rhexis. Let the lens unfold gently, and then use a Kugelin or a Sinskey. Started with thought on the Sinskey, converted to the Kugelin to engage the edge of the lens, and then use my toothless forceps to grasp the trailing haptic and come in and place it right flush under the iris. It did engage part of the pupillary aperture here, and I will use my Kugelin hook to complete the implantation onto the anterior capsule. But as you can see here, I have some lens capture under the anterior capsule that I will come and correct with my Sinskey hook and bring it over. So that way my MA lens is sitting over the anterior capsule and within the sulcus. I have very good support. I will go in and complete the irrigation aspiration, which will make me aware that there's a very tiny thread of vitreous present that will again make me come in back with my vitrector and make sure that I am using acetylcholine here to attain meiosis and make sure that my pupil closes, and also help me to realize if there's any vitreous band engaged, especially I'm using my Sinskey hook to massage the pupil and make the pupillary aperture smaller, and I will soon realize that I do have a tiny vitreous band protruding through my pupillary aperture. I will complete the suturing of this clear cornea incision very carefully. I will end up with 3 interrupted 10-0 nylon sutures that I will start removing the earliest at 1 month, and tapering them according to my keratometry in order to use then this incision as my modulary tool rather for correcting astigmatism. So we're taking here a mishap, a small complication, to unfold all the knowledge from extracap, keratometry, cornea astigmatism, square sutures a must here, and we're burying the knots. Always patient comfort comes first. Filling in the chamber, lens is sitting very well, and we have a finished procedure. I think what I'll do here is I'm just going to replace the first suture that I placed at the 12 o'clock position because it's quite loose, and it won't do the job that we want. Remember that if we suture loosely heal, rather if we suture loosely, the healing will cause much more astigmatism than we would expect. So incision of this arc should correct about a diopter and a half, max 2 diopters of astigmatism, and that will be just fine with what we want to correct as a residual cornea astigmatism left from her original LASIK procedure. So we're at the finishing touches here. More acetylcholine. We're filling in the chamber. We have no vitreous bands protruding. double checking our wound, it's watertight, our paracentesis, and I think it's time to call it a day. We unfortunately ran into a half-hour procedure instead of 10 to 12 minutes, but the take-home message here is that we have to invest the time. So next day we have a patient that has vision of 20/40 with some cornea edema. Remember, this patient had Fuchs pre-op, and besides all the mishaps, we have a very good results. This is John Kanellopoulos signing out. Thanks so much for your attention.